I see that participants are joining, so we'll just, as people are joining, we'll get started in just a minute. And Dr. Teslyar, whenever you're ready, you can share the screen if you're ready. Maybe we wait one more minute. I think people are filing in and then we can get started. All right, well, I will start with introductions. I am Dr. Lena Mittal. I'm the Associate Medical Director for MCPAP for Moms. Welcome to our webinar series, our quarterly webinar series. Today's topic is bipolar affective disorder screening and management for perinatal patients. Just a few housekeeping things before we get started. This webinar will be recorded and the recording will be available on our website at mcpapformoms.org. A copy of the slides will be available on our website as well under toolkits and resources under PowerPoint presentations. Our presenter, Dr. Teslyar, will stop for questions and we'll leave some time for questions at the end primarily. If you have questions, you can type it into the chat box, or you can at the end when we have time for questions, you can unmute yourself and also ask it out loud. You'll receive a brief survey at the end of the webinar and we really appreciate your feedback. So please, if you have a moment, take some time to fill it out. And now it's my pleasure to introduce a friend and colleague, Polina Teslyar, who is an instructor at Harvard Medical School and the director of the Reproductive Psychiatry Consultation Service at Brigham and Women's Hospital. She works closely with myself and then our colleagues at the Brigham, obstetric colleagues, as well as psychiatry. She's a fabulous and committed educator and teacher, and associate program director for our Women's Mental Health Fellowship. Dr. Teslyar trained, did her medical school education at Tufts University locally, and then did her residency at University of Maryland, Sheppard Pratt, and then came back to Boston, which is when I first got to work with her, to complete a fellowship in psychosomatic medicine at the Brigham and Women's Hospital. So Dr. Teslyar is going to speak to us about bipolar affective disorder. So please get started.
Thank you so much, Dr. Mittal. Hi, thank you everyone for joining today. As Dr. Mittal said, my name is Polina Teslyar. I'm one of the psychiatrists at Brigham and Women's Hospital, as well as MCPAP for Moms. And today I'm going to be speaking with you about bipolar affective disorder, both screening and management in perinatal patients. I have no conflicts to report. So today I'll be primarily focusing on the diagnosis of bipolar affective disorder and the epidemiology as it affects perinatal patients, as well as discussion of screening and then followed by management of the disorder. So bipolar affective disorder, which historically previously had also been referred to as manic depression, and sometimes you will still hear patients say that, is a mood disorder that is defined by the Diagnostic and Statistical Manual as having to have both episodes of depression and mania. It's really important to understand the actual diagnostic criteria because unfortunately this is one of those conditions that has kind of entered our language and often is used by patients or even other healthcare providers to describe kind of a certain set of behaviors, but that not necessarily an actual illness. So according to the DSM, depression is defined by 5 or more of the following symptoms that have to be present for a minimum of 2 weeks of duration to meet diagnostic criteria. And like all disorders in psychiatry, there must be evidence of impairment from the symptoms for it to be considered pathology. So to diagnose depression, you need 5 or more: depressed mood on a nearly daily basis, reduced interest or pleasure in activities, weight loss, changes in sleep patterns, so that could either be more or less sleep, psychomotor retardation or agitation, energy loss and fatigue, feelings of worthlessness or excessive guilt, poor concentration, and thoughts of death. Mania, likewise, must be present for at least a week to actually be diagnosed. And mania is described as abnormally and persistently elevated mood and energy. We often think of mania as a euphoric state, but actually some patients do experience what is referred to as a mixed state, where they have that elevated energy and some of the other symptoms, but they're actually irritable, not pleasant. But in addition to the elevated energy and mood state, you also need 3 additional symptoms of inflated self-esteem, decreased need for sleep. This is actually a really important one to clarify, because sometimes patients will misunderstand when you're screening for this and talk about their inability to sleep. Decreased need for sleep isn't just your regular insomnia. It really is a change in need. Patients who are manic don't need to sleep. They don't feel tired. They're not missing that missing sleep, as opposed to patients who may be having trouble sleeping because of their depression, but then are very fatigued the next day. Often there's pressured speech, flight of ideas, distractibility, increased goal-directed activities, and excessive engagement with like high-risk behaviors that have a high likelihood of very negative consequences. And that could be legal consequences, personal consequences, professional consequences. One of the challenges about bipolar affective disorder that I think you all face is the fact that the typical onset for bipolar disorder is usually in the very late teens, early 20s. For women, actually can be into the mid 30s, which correlates rather well with also the reproductive years. Because of this, it is not unusual for a woman to have her first episode of bipolar affective disorder either in pregnancy or postpartum. And so they don't always come in telling you that they have a history of bipolar disorder, because they might not have had it yet. It is a lifelong illness. A single episode of mania does get you the diagnosis of bipolar affective disorder. We do see it as a cyclical illness, meaning that there can be long periods of stable mood in between, but it does tend to relapse. Typical bipolar affective disorder, that mood switch from like manic to depressed only happens a few times per year, maybe 3 to 4 times per year. So that's another really important distinguishing factor from patients who are saying like, oh, I'm like up and down all day. It's not that unusual. According to the National Institutes of Mental Health, about 2.6% of US adults have a diagnosis of bipolar affective disorder. It can be rather difficult to diagnose, especially if you don't have a lot of time to dig into the history. One of the most common misdiagnoses for bipolar affective disorder is major depressive disorder, or what we will sometimes think of as unipolar depression, or just like sort of classical depression. Part of the reason for that is that for most people who go on to develop bipolar affective disorder, usually the first ever mood episode is depression. So sometimes they have already been diagnosed with a depressive illness because they haven't had a manic episode yet. The other thing that we often see is that for patients with bipolar affective disorder is that often that first episode of depression actually happens at a very young age, maybe early teens, rather than more classic unipolar depression, which typically has a more adult onset. The other thing that you will sometimes see with your patients is that postpartum psychosis, although a very rare disorder, but postpartum psychosis typically goes on to prove itself to be bipolar affective disorder. And we treat it as such unless proven otherwise. Besides major depressive disorder, the other things really important to keep on your differential if a patient either reports that they have bipolar disorder, they think they have bipolar disorder, or you're wondering if they have bipolar disorder, is the other disorders that are characterized by mood lability or very frequent switches from up and down. Again, remember, in true bipolar disorder, that mood switch should only be happening a few times per year. So if somebody's telling you that they're up and down, that their mood changes minute to minute, that they're quick to fly off the handle, that is probably not bipolar disorder. That sounds more like either maybe a personality disorder, it could be a substance use disorder, or a trauma-related disorder. The reason I'm talking to you about bipolar disorder is because we know that the disorder, when it happens in pregnancy, can have very significant consequences. So studies show us that if you leave bipolar affective disorder untreated in pregnancy, we do see very significant impacts on both, or on the fetal development, the health of the patient themselves, the pregnancy itself. So from a fetal perspective, we see that with untreated illness, there's a higher rate of prematurity, low birth weight. The fetuses are often small for gestational age. There's evidence of intellectual and cognitive delays. Women with bipolar affective disorder, unfortunately, are much less likely to engage in good prenatal care. They're more likely to have higher C-section rates, preterm labor, and preeclampsia. We also know that untreated bipolar affective disorder correlates with really high-risk behaviors, such as increased rates of substance use, hypersexuality. You know, that can lead to significant increased risk of the patient exposing themselves to harm, right? Either from contracting an infection or even just putting themselves in high-risk situations where they may be physically harmed or abused. That sort of behavior, the high-risk behaviors, can also lead to loss of support of either, you know, their partner or other friends or family members in their lives. And unfortunately, suicide remains a leading cause of death in the postpartum population, and certainly is higher with a diagnosis of bipolar affective disorder. One of the things that we still encounter very frequently is patients who come into our clinic and say, well, I am pregnant, so I stopped all my meds, or I am pregnant and my doctor told me to stop all of my meds. This is a concerning thing because we know without a shred of a doubt that pregnancy is not a protective state for mood disorders. The two graphs you're looking at here, so we'll look at the green one first. In that green bar, what they're showing us is what happens if a patient discontinues their mood stabilizer abruptly. And as you can see, the relapse rate is 100%. Now, they compare that to what they called a gradual taper, meaning that they taper the medication over 2 weeks. And there is a lot of improvement there. The relapse rate is only 62%. I would still argue that that's completely unacceptable. The second graph is looking at the postpartum period, so the first 6 months after delivery. Blue line is women who were not pregnant. They just happen to have stopped their meds. And then what happens if you follow them for 6 months? This is a survival curve. So as you can see at the end of 6 months, the rate of relapse is a little over 20%. Whereas if you look at the postpartum patient, if they are not on medication in that first 6 months postpartum, their relapse rate is virtually 100%, approaches 90% at that point. We know that women who are in the first year postpartum are about 13 times more likely to experience an episode of depression or mania than any other time in their life. So it's really important to keep that in mind. That pregnancy is not a protective state. If anything, it's a much higher vulnerability state. The most common cause of relapse in either depression or mania in pregnancy is discontinuation of medication. So hopefully we have some control over that and can help educate our patients about why that's not a good idea. I already briefly mentioned postpartum psychosis, very rare event, thankfully. Most people can probably go their whole career without having seen it. I think here at the Brigham, we get maybe 1 or 2 cases a year. Nearly all patients who have an experience of postpartum psychosis do go on to show themselves to have a bipolar affective disorder, even if this was their first episode. The other swatch of patients are basically people who already had a known psychotic illness. So, you know, women with schizophrenia can have a postpartum psychosis because of their underlying psychotic illness. Postpartum psychosis, typically when it does occur, occurs in the first few days postpartum. So sometimes we actually will see that before they're even discharged from the hospital. One thing to keep in mind that unlike some of the other more classic psychotic illnesses, postpartum psychosis often initially presents with a picture that looks more like delirium. So there's more like confusion and agitation rather than frank psychotic symptoms. So it's really important to make sure you're ruling out all the other medical causes of altered mental status in the postpartum stage and monitoring very closely. For psychiatry, we consider this a true and very serious emergency. I always counsel my patients that they have any concerns about this happening to go straight to the emergency room, because unfortunately, there is about a 4% risk of infanticide if postpartum psychosis exists. It is important to differentiate symptoms of postpartum psychosis from other very normal worries and thoughts, maybe even intrusive thoughts about harming the baby. It is really common for women postpartum to have this almost like OCD-like picture where they're having these really bothersome, intrusive thoughts that they might accidentally hurt their baby. I always tell my patients, if you're worried about it, I'm not worried about it. What I mean by that is that usually in the normal picture, they have insight into that this would be a terrible thing. They're really distressed by it. In fact, they're often afraid to bring it up because they're worried they're going to be judged, or that you might like call DCF, or somebody thinks that they'll actually do this. The thoughts don't make sense to them. Like they might have thoughts. I've had a patient who, was very worried that while she was making dinner, she might accidentally cut her baby with the knife, even though the baby was safe in his bassinet across the room. This is distressing for the patient, but it's not something where I'm worried the baby's actually at risk. With postpartum psychosis, the thoughts make sense to the patient. They're kind of consistent with whatever psychotic or delusional state they're in. And so they might be thinking that they need to microwave the baby to get rid of COVID germs, or that they have to do something to protect the baby from demons. That's where tragedies can happen. And if you feel that that's happening with your patient, it's really important to get them evaluated immediately. Like most things in life, I think the most important thing when you think about management of bipolar affective disorder is to start with preconception planning and plan ahead. It's really important to think about how to have this conversation with patients. And if there's no other kind of message that you take away from this talk, I think the most important thing to remember is that there's no such thing as a risk-free option in this situation. So when patients are talking about discontinuing their medication because they're worried about the impact this may have on the health of their pregnancy, it's really important to put that in the context and educate them about, well, what are the risks if your illness is untreated in pregnancy, and recognize that we're weighing risk versus risk here. The other reason it's really important to talk about these things preconception, and this is both true for the treating psychiatrist if we're picking a medication regimen, and also if you have a patient who's coming to you because they're looking to get pregnant. The other flip side of that is also to think about pregnancy prevention. Women with bipolar affective disorder, if they're in a manic state, are more likely to engage in high-risk behaviors, so they may be doing things that they normally wouldn't do that may increase the risk of an unplanned pregnancy. The other thing to think about is that some of the mood stabilizers that are used to treat bipolar affective disorder can actually affect the metabolism of oral contraceptive pills, make them less effective, so again, increasing the risk of unintended pregnancy. Specifically, topiramate and oxcarbazepine are potent inducers and can make OCPs less effective, so you have to kind of think with a patient about how are they going to do their family planning. When I think more about management of specifically bipolar affective disorder with preconception planning, we always talk about, what are the meds that you're taking? What are the meds that are working for you? What do we know about the safety of these medications in pregnancy? Would it be okay to stay on them? I also like to bring up with a patient the idea of thinking about a birth plan. And I don't mean this here the way sort of people use it sometimes as like what kind of atmosphere they want to give birth in, but more thinking about, are there things that we can anticipate that might be hard for you as you go through your pregnancy and delivery? So women with bipolar affective disorder are more likely to also have a history of trauma. So there may be things associated with pregnancy or the necessary care that may trigger some of those experiences for them. Maybe they've already had a delivery in the past. How did that go for them? Was that a positive or difficult experience? Just trying to anticipate what is it going to be like to be a patient? What's it going to be like to be in the hospital? Sometimes, patients can be worried about feeling judged if they're taking medications when they're pregnant. So just kind of thinking those things through. I also like to talk to my patients about creating a worst case scenario plan. So this is what I mean by creating an advance directive. Let's say we do everything we can to keep you stable, but it still happens. You get either very depressed or very manic. What are we going to do in this situation? Is there a person in your life that you can trust and designate to be the first one to kind of raise an alarm and say, hey, I don't think you're doing well. You're talking too fast. You're not sleeping. Let's call your doctor. Or, maybe that person would even call me directly and say, I'm worried about what's going on at home. I think she needs to be seen. We talk about which medications would we use, which medications are absolutely not to be used, which hospital would you prefer to be hospitalized, ECT, TMS, would those all things that we would consider if necessary. If there's already children in the house, who would step in and take care of them if you're not able to do that? What if you needed to be in the hospital for us to take care of you? Who would do that? And so it's really important to have collaboration with, the family or the support network, as well as the obstetric team, and then possibly pediatricians, depending on which medications we're choosing and what we think might happen postpartum with the neonate. I always talk to patients as well about what their thoughts and goals around breastfeeding are going to be, keeping in mind that flexibility is really important. Also recognizing that not only do we think about what medications are you taking and what impact that might have on breastfeeding, and that can be a variety of impacts, whether it's safe to breastfeed on those medications, whether the meds themselves can affect lactation, but also thinking about the reality that a newborn infant needs to eat every 2 hours. And we know that lack of sleep is probably the single most common trigger for manic episodes. So is it in the patient's best interest? Is it in the neonate's best interest to be breastfed if it risks destabilization? Are there other people around who can help care for the infant so that the patient can sleep? Sometimes that's not really an option. Related to that, we think about, as I said, sleep protection, bonding, and then of course, very close monitoring throughout the pregnancy. In terms of medication selection, unless there's a good reason not to, I always want to stick with what has worked in the past. So if this patient has been in treatment, they already have a diagnosis of bipolar affective disorder, first place to start is like, well, what's worked for you? What's kept you stable? Because the last thing we want to do in pregnancy is create switches and create additional exposures because we decided to try the gold standard medication, but then it turned out that that wasn't the right or effective choice for the patient. There are some exceptions to that, and I'll get to that towards the latter part of the talk. There's a very common natural instinct to lower the dose. And it's true, we do want to use the lowest dose possible, but it still needs to be effective. So I always stress that we are using the lowest effective dose because the last thing we want to do is have a double exposure of medication plus illness. The other thing I always educate my patients about is that actually, as your pregnancy progresses, probably we're going to be increasing your dose. Many of the medications we use for the management of bipolar affective disorder their metabolism is affected by the changes that happen in pregnancy. So especially lithium and lamotrigine, you're pretty much guaranteed you're going to be increasing that dose through pregnancy. So I always want to caution and warn the patient up front that if you feel like your meds aren't working, let me know right away. And also don't be surprised if I'm increasing your medication. Don't be upset about that. The flip side of that is as soon as they deliver, we got to get it back to the pre-pregnancy state fairly quickly to make sure we don't reach toxicity. When we're thinking about medication, we also are thinking about what trimester the patient is in. If the patient presents and they're already in the second or the third trimester, then maybe those concerns about cardiac issues with lithium are not something you're thinking about right now, but now you're thinking about, is there going to be like a withdrawal syndrome at the end of pregnancy? And then again, thinking about breastfeeding goals. Unfortunately, some of the medications that are safer in pregnancy are then a little more difficult than breastfeeding and vice versa. For mood stabilization of bipolar affective disorder, a lot of the medication we use overlap with the seizure meds, the AEDs. And so a lot of the pregnancy safety data actually doesn't come from psychiatric illness, but comes from epilepsy. So when we use those medications, just like neurology, we do recommend a high dose folic acid to go along with the AEDs to prevent neural tube defects. That's actually another good point to remember that, the studies that we have for the safety of these medications to be used in pregnancy are all observational based. Obviously, nobody randomizes. women to take a medication like this. So you always have to think about the confounding variables that, you know, the patients being studied have an underlying either psychiatric or neurological illness that is being treated with the medication. And again, very important to be sure of your diagnosis when you're providing treatment. So the most common misdiagnosis of bipolar affective disorder is unipolar depression, or MDD. The reason I'm stressing this again is because while SSRIs are the gold standard for treatment of depression in major depressive disorder, if you give an SSRI to a patient with bipolar affective disorder, you're actually very likely to make things worse. You could either trigger a full-on manic episode, or they won't become fully manic, but they get more irritable, and like the medication doesn't seem to be working. So when you're screening patients for depression and thinking about starting treatment, it's also really important to screen and rule out bipolar disorder before doing that. The other thing to remember is, remember we talked about how bipolar affective disorder is a lifelong illness, but it is cyclical. So if a patient tells you that they have a history of bipolar disorder, but they appear euthymic and stable in the office, and they're like, I'm fine, I don't need to take my meds, that may be true right now, but the chances that that's going to change are very high. So there needs to be very close monitoring in that situation, as we know that pregnancy is not a protective state. Speaking of screening for depression, you're probably more used to doing this because it is a more common disorder, and the screening tools are more widely used. So of course, for depression, the most common screening tools that we use in the perinatal population are the Edinburgh Postnatal Depression Scale and the Patient Health Questionnaire, the PHQ-9. These questionnaires are self-report and focus mainly on symptoms of low mood, right? So trouble sleeping, low energy, low interest. If you're screening for mania, the better tool for that is the Mood Disorder Questionnaire. This one is screening for the ups. Too much talking, too much energy, too many projects, people can't follow your train of thought, feeling too good about yourself, those kinds of things. So again, we do recommend that when you're screening, either for depression or bipolar affective disorder, you want to kind of ask both those sides. So you're screening for the lows, you're screening for the highs. If you're thinking that you have a patient that you want to start an antidepressant on, please do take the time to screen for bipolar disorder just in case, so that you're not accidentally giving an SSRI to someone who is going to feel worse from it. The initial screen is fairly simple. It's basically 2 questions that focuses on, do you feel up? Do you have too much energy? Don't need to sleep, doing too much stuff, feeling too good. It is really important to remember that time period, because it is very common for patients to say, yeah, I've had that where I've been like, you know, I pulled an all-nighter and I was really productive and I painted my house. And so you really want to kind of get, but how long did that last? Was that just one night? And were you planning to do that and you just were able to achieve it, or was it more of an impulsive thing? So if in doubt, of course, we're here to help. You can always call us and we can talk you through it as well, or using the more formal questionnaires to get like a way to ask that in a more systematic way. So moving on to actual management and medication choices, mood stabilizers are a larger category that can be a number of different things. So we think of antipsychotic medications as mood stabilizers. We think of AEDs as mood stabilizers. Lithium, of course, is also a mood stabilizer. What this graphic is showing you is the safety data for use of mood stabilizers in pregnancy. Please notice that valproic acid, Depakote, and carbamazepine, oxcarbamazepine are in the avoid. I cannot think of a single situation in psychiatry where we would be using valproic acid in a pregnant patient. In fact, we really try to avoid using them, using valproic acid in reproductive age women. I know for neurology, it's a little bit different. For some patients, that really might be the only seizure medication that they have access to that actually controls their seizures. But we do have other mood stabilizers in our arsenal that are much safer. So we really don't want to be using that. Notice that the typical antipsychotics, so these are the older drugs, things like haloperidol, are thought of as a little bit safer compared to the atypicals. Those are the more new drugs like quetiapine, olanzapine. Partly that's because we have more data. Haloperidol has been on the market since 1968 and was used for management of hyperemesis gravidas. So it's actually the only psychiatric medication we have that has safety data on women who don't have psychiatric illness. Atypical antipsychotics are newer, so there's a little bit less data on them. There's also emerging literature to suggest that there's a very significant risk of increased rates of gestational diabetes with their use because they do make people gain weight. Lithium is kind of in the middle. I would say that it's really underutilized in pregnant patients because people are scared of Epstein's anomaly. But it can be used safely, and for some patients, it really is the only thing that helps them maintain a stable mood. Lamotrigine, very commonly used in pregnancy. The only downside to lamotrigine is it takes a very long time to get to a therapeutic dose. So if the patient has active symptoms, it may be difficult to use that one in that situation. Oops, sorry. Now this is looking at breastfeeding. So this is what I was referring to, that there is actually a flip. Lithium is harder to use in breastfeeding because the neonate needs to be monitored because there's significant lithium passage in breast milk. So you have to work with the pediatrician to make sure that they're monitoring the baby's levels. Valproic acid, on the other hand, is thought to be safe in breastfeeding. So sometimes patients will make a switch back and forth depending on what their goals are. Just to go through some of the more important medications briefly. So lithium, definitely gold standard treatment for bipolar affective disorder in non-pregnant patients. I do think it is underutilized in pregnant patients because it can be a little bit difficult with the monitoring needs. It does have some cardiovascular heterogeneity, specifically Epstein's anomaly. And the other thing that we worry about a little bit is lithium can lead to diabetes insipidus and so nephrogenic diabetes insipidus, so that can lead to polyhydramnios for the fetus. At delivery, we do see some transient hypothyroidism that does resolve. Sometimes the babies are a little floppy and lethargic. They can be big, actually, for gestational age, even though there is a higher rate of prematurity, but most of these things are fairly transient. We don't see any developmental, like neurodevelopmental or cognitive difficulties with lithium. It will require a dose adjustment towards the end of the second, beginning of third trimester. Lithium is completely renally cleared. So when that renal clearance rate goes up, the lithium level will drop and the patient may start to be symptomatic. We also advise patients to be really careful to monitor their fluid intake, their caffeine intake, avoid the use of NSAIDs. Because of that dependence on renal clearance for the level. If the mother chooses to breastfeed while she's taking lithium, the neonate does need to be monitored by the pediatrician for lithium level, thyroid level, renal function, etc. Because of that, a lot of patients will choose not to be breastfeeding if they need to stay on their lithium postpartum. We do recommend lowering the dose postpartum if it went up in pregnancy. So sometimes we'll either hold it for a day and then check the level and restart, or just check a level and lower it. But that change actually happens really quickly. So you're going to be doing that within like, the day of delivery or like the next day. Lamotrigine is another interesting one and one that we use very often. GlaxoSmithKline, the manufacturer of Lamictal, has their own registry, so a patient can kind of enroll in that if they're taking the medication in pregnancy. The lamotrigine literature mostly comes from neurology, so from their medication arsenal, it looks like it's probably the safest with the least amount of malformations. There is still some concern about increased risk of cleft lip and palate with lamotrigine, although that's less clear. We do recommend a high dose folic acid when patients are taking lamotrigine. I think if you're managing a patient on lamotrigine in pregnancy, the most important thing to remember is that estrogen is a very, very potent inducer of lamotrigine metabolism. And so when the estrogen level goes up at the end of the second trimester, the lamotrigine level drops very precipitously. Some patients will require about a 300% increase in the dose to regain effectiveness. This is actually true in non-pregnant patients. If you start somebody on oral contraceptives and they're on lamotrigine, you're also going to drop their level, so they might need an adjustment. Sometimes if a patient is planning pregnancy and they're doing really well on lamotrigine, we will actually get a blood level just to help us figure out when they're pregnant, if their levels are difficult to maintain, what our target is. There is transmission of lamotrigine in breast milk, but it is thought to be safe for breastfeeding. As I mentioned, the older antipsychotics are thought to be quite safe in pregnancy. Data goes back to the 60s. We don't see any evidence of teratogenicity. There is a small risk of transient sort of like shakiness and jitteriness in the neonate that goes away. We don't see any evidence of long-term neurodevelopmental problems with these medications. They're also pretty safe in breastfeeding. We don't really see any problems with them. Some of the first generation antipsychotics actually can increase lactation. Atypical antipsychotics are a little bit more mixed. Of the atypicals, quetiapine is thought to be probably the safest choice in pregnancy because it has the lowest amount of placental and breast milk passage. However, like I said about lamotrigine, quetiapine can take some time to start working, and it's really sedating, so it can take a while for the dose to get to a therapeutic range. So it's not always the best choice in an acute situation. Again, quetiapine can lead to very significant weight gain, so we do worry about gestational diabetes with it. Risperidone is a little closer in its structure and function to the first generation drugs. There was a study recently suggesting that there may be a slightly increased risk of cardiac issues with risperidone. So not clear yet. We probably wouldn't change practice if that's a medication that's really been effective for the patient, but something that bears watching. There is an increased risk of premature delivery and birth and low birth weight with the newer antipsychotic medications. And the other one that we sometimes think about too is aripiprazole has a very different mechanism of action. It's an agonist-antagonist for dopamine and can kind of affect prolactin levels. So there is concern that with aripiprazole, it may be difficult to initiate lactation. And that's something that I'll sometimes talk to patients about if they're using aripiprazole, just to kind of keep an eye on how things are going if they want to be breastfeeding. Because these medications are newer, there's less long-term data to know the safety profile. As I said, medications we absolutely don't like seeing in pregnancy, don't want to see, are valproic acid and carbamazepine. As you can see from here, they basically affect everything. There's very significant teratogenicity from these medications. In studies, average IQ loss is about 9 points with valproic acid. Very strong connection with autism. It does seem to be dose dependent, but it's okay in breastfeeding. Carbamazepine, not as bad as valproic acid, but still not good. And together, they're synergistically much worse. Sometimes for bipolar disorder that's really difficult to treat, it's actually not an unusual medication combination of valproic acid and carbamazepine. But hopefully, if a psychiatrist is doing that, they're really counseling the patient to absolutely avoid pregnancy. These are some suggestions from the NIH about what kind of monitoring a neonate or infant would require if the mother chooses to breastfeed on these medications. It looks more difficult than it really is. Lithium is really the one that needs kind of ongoing monitoring. Everything else, I think that usually it's checked in the beginning, and then if everything's okay, they can continue to breastfeed. So in summary, we really want to think about maternal mental health because it affects not just the patient in front of you, but the offspring, the family, the whole unit, keeping in mind that many pregnancies are still unplanned. So we have to be really careful when we're thinking from the psychiatric perspective, when we're coming up with a treatment plan for a patient, that what are we going to do if we find out that they're unexpectedly pregnant? It is really important to screen for mood disorders in pregnant and postpartum women because we know that unfortunately pregnancy state is not protective. It's actually very high risk. And then when making treatment decisions and recommendations, really thinking very carefully about the risks of untreated illness and how that weighs against the risks of the medication that might be used to treat the illness. Here's a list of resources that I think can be really helpful. Of course, MCPAP for Moms. MGH has a really nice website that I often will refer patients to. It's written kind of like for the lay public, but it has a nice sort of synthesis of like emerging data and literature, and they do a pretty good job of staying on top of it so that if there's some study that hits the lay press about like SSRIs and autism or something like that, that the patients can kind of go look at a reliable source of information. LactMed is a free app from the NIH to look at safety of medications and breastfeeding. And then Mother to Baby is a similar program as well. And then this is our team. Thank you very much, everyone, for helping me prepare this talk. That's it.
Thank you so much, Dr. Teslyar, for that great talk and a whirlwind tour of a pretty difficult topic. We had one question already posted in the chat, which I tried to address in the chat, but also might benefit from a little bit of a discussion. Rachel, do you want to unmute yourself and ask your question about the terminology? If you're still on.
I don't think Rachel is still there. But so the question was about the bipolar 1 and bipolar 2. So basically bipolar 2 is less severe bipolar. It speaks more to the manic side of the illness than the depressive side, but usually bipolar 2 is thought of as depressive illness plus hypomania, maybe not full criteria manic episodes. One of the other distinguishing criteria in the DSM is whether the patient has required inpatient hospitalization for management or not. But from a treatment perspective, the medication management is the same for both. And I'm not aware of studies looking at bipolar 2 specifically as it relates to pregnancy. Maybe if a patient really has bipolar 2 disorder and they really want to be off medication, it'd be a little less scary to monitor them that way, but I would treat it as bipolar disorder.
Thank you. If there are other questions from participants, please put them in the chat. Dr. Teslyar, I have a question. I thought, this is something that kind of comes up in my clinical practice. And I was just this morning talking with a colleague who described a patient with pretty significant mental health issues previously diagnosed as bipolar disorder. And the patient described to this colleague of mine having been told that she should not have children. And so how would you sort of address this when somebody has a pretty significant and serious mental health issue? This particular person that we've been talking about had hospitalizations and required was stable now on multiple medications. How do you talk about reproductive life planning with that?
This question does come up quite often, and it comes up in a variety of ways. Patients either feel like maybe their bipolar illness is so brittle that they worry about what effect would pregnancy have on their own health, what effect would their disorder have on their ability to parent. Sometimes we actually get this question from reproductive endocrinologists when they have a patient who is coming to them for fertility treatment and they're like, well, I'm not so sure that this is in your best interest. So I think that it's a very nuanced question, and there's a couple of things to consider. So, one thing that patients will sometimes ask is like, I have bipolar disorder. What are the chances my kids are going to have it if I have kids, if I have biologic kids? And, we don't have an exact answer for that. We do know that bipolar affective disorder, at least to some extent, is genetically linked. And so the chances that there would be mental health issues in the offspring is higher than like the general population, but we don't know exactly what that risk is. We also will talk to patients about what are the things about pregnancy that are destabilizing and create a high risk situation? So the hormonal changes, do they have a history of hormonal sensitivity? Do they find that their illness is affected by their menstrual cycle, or if they've had oral contraceptive treatment in the past? Sleep deprivation. If a patient knows that even just the most minor disruption in sleep can make them very ill, then we think about, well, what can you do to mitigate that risk? And I think this conversation can be very different depending on the patient's situation. Like if you have a patient with significant bipolar history and high vulnerability, but they have people that they can rely on, they have a family that they're a part of, or a partner or friends, a community that can step in and help them, helps take care of the offspring, that's very different than someone who's maybe facing having to do this by themselves. And also in terms of like, what are realistic options to mitigate that risk, that sleep deprivation, again, is breastfeeding their best interest or not? These are all very nuanced. I would never tell a person that they absolutely should not have children. I don't think that's my place, but we can talk realistically about like, well, maybe you've had 5 or 6 hospitalizations in your life. And so we expect that there will be more. Is that going to impact your kids? Yes. Are there things there that, supports and safety nets that you have that can help? I think it has to be a very individual decision. I mean, in some ways, it's almost reassuring when a person is asking those questions, because it's usually what happens is that the patient has an unplanned pregnancy, right? Is that they're in your office because like, surprise, I'm pregnant, rather than like, I'm thinking about it and I'm worried about it. So I sometimes will tell my patients, the fact that you worry about these things and think about these things already makes me feel better, that, that your chances of success are better. But it's really not that different from somebody who has any kind of chronic health problem, right? I mean, on the consult service, we see women who have very serious cardiac risk factors for pregnancy, or maybe they have immunological disorders or neurological disorders, or they have to take really kind of sort of scary meds to keep themselves safe. And so what are they going to do in pregnancy with all of that?
Yeah, these are challenging issues.
Yeah, thanks. Thank you, Dr. Teslyar, for the talk. It was great. And I have a question, this is sort of a thing that I often come across, where people, a lot of times when I see people, they come having diagnosed with, a lot of times there's a lot of confusion between PTSD and bipolar disorder. Yes. So I was wondering if you could speak to that, because many times people themselves will come and they'll say they have both. There's sort of like, there's just a lot of confusion around the diagnosis of that. And there's so much sort of, so curious if you could speak to that a little bit.
Yeah, and that is a really challenging question, and not to have like a cop out, but I would say like that may be a question to bring to MCPAP if you're really confused, because I think even for a seasoned psychiatrist, it can often be really hard. If you remember when I talked about the differential diagnosis, one of the things that's challenging is trauma disorders, certainly. Substance use disorders, right? If a patient has this up, down, sometimes I have hallucinations, sometimes I go for weeks on end without sleep, but I'm also using meth or cocaine when I'm doing that. It can be really hard to know chicken and egg, because, I remember when I was training in medical school, there was a lot of this kind of concept of like, you can't diagnose bipolar disorder in someone who's using substances. And even in just the time, of my residency, the thought was like, well, actually people with bipolar affective disorder are more likely to also have a substance use disorder. So you can't really say like, until, you're sober for a year, we can't give you a diagnosis, but it can be really challenging. And so I think it's really important to get that really good history of, do these things happen when you're not using substances? And these switch periods, these up periods, are we talking hours? Are we talking days, weeks, months? Are we talking it happens every other week, or like once every 3 years? I think that really differentiates things. And with the trauma disorders, it can be really difficult too, because patients may not readily tell you that they have a trauma disorder, because they themselves may not recognize that they have a trauma disorder. A lot of patients think of like PTSD as related to like soldiers, or, like a rape, like something really big and obvious. But a lot of our patients carry little traumas that they don't necessarily think to identify that way, because it's like their normal life. it may be even look like normal for the people in their lives to have had those experiences. And so they don't always recognize that their like emotional instability and ups and downs are more related to triggering of those traumatic events rather than an actual mood disorder, as we think.
Thank you. Yeah, I agree. I see many individuals who don't know they've experienced trauma. When I speak with them and ask a lot of questions, you're like, that sounds traumatic, but people don't recognize it as that because it gets sort of normalized. Yeah, it's really important. Thank you.
I might just turn back to our participants just to see if anybody else has a question. It looks like we have a question from Dr. Okwaraku, who is asking talking about the co-management of bipolar and ADHD, and if you have some thoughts about that. Really a vexing issue.
Yes, and also excellent question that it often actually can be really difficult to distinguish ADHD from bipolar disorder, which is funny because it doesn't sound like it should be. It seems like those are totally different things and it should be very obvious, but actually it's not. And part of the reason why it can be hard to distinguish is because often, especially if ADHD is unrecognized in childhood, it can lead to sort of like maladaptive coping or like anxiety and mood issues. Which can then be, again, hard to distinguish later. So again, the timeline. So that distractibility, that hyperactivity, impulsivity, is that an everyday thing? Is that something that's just like almost seems like a part of the person's personality and character, or is it episodic? Bipolar affective disorder is episodic. It cannot be that you're always manic. It cannot be that you're always bipolar. You have to have periods of time in between where the mood is more or less stable, as opposed to ADHD, which generally should be there always if it's not treated. One of the challenges with ADHD treatment in bipolar patients, because certainly you could have both, is that, you know, there is always the risk of triggering a manic episode if you give somebody a stimulant. So usually what we would recommend if you're managing a patient with ADHD and bipolar disorder, that they should be on a mood stabilizer first, and then you can cautiously add in their stimulant. In pregnancy, this gets even more nuanced because, as I said, everything is a risk-benefit discussion. So the discussion of taking a mood stabilizer versus risking manic illness, I think, is a different discussion than thinking about taking a stimulant and managing, you know, ADHD symptoms. And so with ADHD, that could be a whole other webinar that we do, but you know, that risk benefit analysis of how bad are the symptoms. Are we talking about you're getting into car accidents? You're at risk of losing your job, or like it's just inconvenient because you keep forgetting things on your grocery list. So I think if you have three things going on, if you have pregnancy, bipolar disorder, and ADHD, those should be separate risk analyses discussions. And you know, and so thinking like almost like a Venn diagram, like thinking, okay, pregnancy risk with bipolar versus the meds, pregnancy risk of ADHD versus the meds, and then the risks of like ADHD meds and bipolar illness. So I don't think that I would ever have a pregnant patient on a stimulant who has bipolar disorder and not on a mood stabilizer. I could not come up with a rational explanation for that scenario.
Yeah, and I think what you're highlighting is that, you know, each condition carries risks, and then those conditions can also impact each other in addition to also parsing them apart. So it's possible to have both, also possible for one to confound the other. It's really challenging. And also a place where MCPAP for Moms can be really helpful if we could, you know, these would be great times to call us because it's hard for even us. And we do this a lot. And so one of those things where it's like better not to worry alone, as we say.
Yeah, and it gets even nuanced with trimester, right? Like you may feel more comfortable doing something in the third trimester than you did in the first trimester, and maybe postpartum versus waiting a little bit, you know. So it's unfortunately very nuanced. And one of the things I love about psychiatry is we don't have these clear-cut algorithms, but it does make it more difficult to practice.
Well, one more question in the chat. Thank you. Just reviewing the use of Haldol as a mood stabilizer and why is Seroquel a preferred agent that we often recommend?
So I guess I'll start with the second preferred. So Seroquel is only a preferred agent in the atypicals. because it is thought to have less placental passage and less milk passage, I wouldn't say that Seroquel is a preferred agent to haloperidol. And some of this kind of, I think, is stylistic. So you're not going to get everyone to totally agree on this. And no, as far as I know, no one's ever like really studied them head to head. I prefer to use haloperidol. I prefer it because it's old. I'm more confident that there's more data. I think that the risk of like the side effect profile risk is acceptable, and it works quickly. I tend to not use as much Seroquel unless there's also other reasons, like the patient's really anxious or they've already been on it and it's helpful for them. But, you know, it all depends. Like Seroquel takes a while to work. It's really sedating. It makes people gain a lot of weight. So it's not always the right choice. And I wouldn't think of Seroquel as better than haloperidol. It's just if you were thinking like olanzapine, risperidone, Seroquel, then you might go with Seroquel from those choices.
And I think if I'm understanding the question, I think part of that, what's embedded in the question is whether Haldol is a good mood stabilizer.
Yes, yes, it is.
Thank you. It's always, you know, very much a relative risk and relative benefit discussion. So there aren't really bright lines here always. Thank you so much, Dr. Teslyar. If anybody in the audience has another question, we have a few more minutes, but if not, thank you all for joining us. This has been such a great talk. It's a tough topic and something that MCPAP for Moms, you know, is here to help parse out. Well, thank you all for joining us, and thank you, Dr. Teslyar.
Thank you.